Hello, welcome. Oh, we already have a hand raised. No, I'm sorry. So my name is Elizabeth Donner, and I welcome you to our PAMI webinar. I'm just going to pause for a moment because, Allison, on my screen, I'm unable to see if there are people who have joined. So I don't know if I should start or not.
Yep, we're
To
all
my other,
set. Yep, you can get
okay,
started.
great. Wonderful. For some reason, I don't have that little counter of the number of people. So welcome. Welcome to our Partners Against Mortality in Epilepsy webinar. Our topic for today is around guidelines, existing and emerging SUDEP guidelines, and how can we bridge the gap between recommendations and practice. And this topic really grew out of some discussions I had with our PAMI leadership, including Gardner Lapham and Allison Kukla, who are joining us today, around why is it that even though we have guidelines asking people to talk about SUDEP, for example, then we really don't see a lot of uptake of that practice among neurologists and healthcare practitioners. So that's what bred this topic for us today. And so I'm hoping you'll all enjoy our discussion. I'm a pediatric epileptologist and the head of neurology at the Hospital for Sick Children in Toronto, and I am moderating our webinar today. And it's wonderful to know that so many people are joining us from really around the globe. So a few housekeeping items. There is a Q&A there's a Q&A on Zoom, so you can put your questions in there, and we're going to do questions at the end, but you can enter your questions as our speakers are speaking, so throughout the webinar. Of course, we can't give specific medical advice, so try and keep your questions general. And of course, if you have specific medical questions, we hope you can direct those to your healthcare team. If there's a question that you really want answered live rather than typed into the chat, you can upvote the question in the Q&A box. So just indicate that, and we'll do our best to get to it during the webinar. You can also use the chat to talk to others or make comments if that's something you want to do. And lastly, so you know, we are recording today's webinar and it'll be available in about 24 hours, and we'll send an email to everybody who registered once it's available. There's a little bit of information that I just went through. And I would like to, just before I introduce our speakers, I would like to thank the International League Against Epilepsy Young Epilepsy section, and we have a speaker joining us today, Eugenia Rosa from that group, for their support of today's webinar. We are very grateful to all the speakers we have with us today. During this webinar, you'll hear about different international and national guidelines regarding SUDEP counseling and seizure detection. We know that the uptake and implementation of guidelines into routine clinical care has remained quite variable across regions and health systems. So our speakers are going to address these central questions. What SUDEP-related guidelines currently exist and are on the horizon, and what evidence tells us about how they're being used in practice, and perhaps how we can better translate recommendations into meaningful clinical action. I will introduce our panel now. So our first speaker will be Dr. Rohit Shankar. He is a professor in neuropsychiatry with the University of Plymouth Medical School and director of the Cornwall Intellectual Disability Equitable Research Unit. He is the Associate Dean for Academic Training for the Royal College of Psychiatrists. Our second speaker will be Dr. Johan Zelano. He is a professor of neurology and senior consultant physician at the University of Gothenburg in Sweden. His clinical and research work focuses on mortality and long-term outcomes of epilepsy, with a particular interest in population-based and registry-based studies. And our last speaker will be Dr. Eugenia Rosa. Eugenia is a pediatric neurologist in Bucharest, Romania, with a clinical and research focus on childhood epilepsies and rare neurological disorders. She is actively involved in international epilepsy education and advocacy, and is the chair of the ILAE, or International League Against Epilepsy's Young Epilepsy section. Thank you so much for joining, to the three of you. I'm really thrilled to have you here. So now we'll start. Rohit, I'll ask you to be our first speaker and share your slides. And then when you're done, I'll ask Johan to start. I will stop sharing and invite you to start sharing.
Perfect. Thank you. I hope that's visible.
Not for me at the moment. Try again.
Oh. Is it not?
No. Oh, Eugenia, you see it?
I can see it.
Okay, there's
okay.
something funny about my link. Okay, you go ahead.
Okay. Fine. I'll get back to sharing that. Hopefully.
Yep. Go
Is that
ahead.
okay?
Mine will get
Brilliant.
sorted. Yep, it's great.
Right. Thanks, everyone. And thanks, Elizabeth, for the introduction. And it's a pleasure to be here. As you can see, I'm a big fan of 60s low-scale spaghetti westerns. But I think the moral here for me is that there is the good, the bad, and the ugly. And I'll be showcasing in our journey about SUDEP communication, what the good, the bad, and the ugly that I've encountered across 5 countries. Very quickly, this work wouldn't have been done if it hadn't been for many of like-minded people, many faces, if not all, which you will recognize. There's, of course, me and my disclosures, Dr. Oliver Henning from Norway, who led the Norway end of things, Dr. Kelman from Budapest and Hungary, and Vincent Villuera from Spain, and, of course, Professor Tobon Thompson. I'm sure everyone in the world of SUDEP is well aware of his work, and he was there supporting it from Sweden, along with Johan, actually, who joined in through the project. What I want to talk to you in the next 8-9 minutes is about the prequel as to how did we get actually doing this five countries project around understanding what SUDEP and seizure counseling is happening in different countries. It's about trying to bring about a level playing field. And we look to first actually set up a validated survey. I'll be briefly touching on that. The main reason was that we needed to understand what's happening, good, bad, and ugly in different countries so that we can learn from each other and share our problems. And today's journey is a bit about that. So it's very much as Donald Rumsfeld highlighted, it was about moving the unknown unknowns to the known unknown. And I think this is the journey that we have succeeded in doing that. And part of it is addressing the blind spots and trying to understand what are the major gaps in it and why they exist. And I can share some learning around that. And as I mentioned, it is about some of the quick wins. How can we actually, what are the low-hanging fruits and how can we actually get some solutions out? And I think that is important. So it is about not about good care. It's also about talking about good enough care and where that comes, especially with regard to communication and counseling. So I'm pretty confident that many here, if not all, already know all this. So I'm going to be sort of rushing through this. And as you know, that SUDEP is an issue. It's a major issue where, especially in the care of epilepsy, where newly diagnosed 1 in 10,000 patient years, there is deaths, chronic epilepsy 1 to 2, heterogeneity in that population, particularly when it comes to pharmacoresistant epilepsy in people with intellectual disability or those with surgery. There is variance and it can be significantly higher as time goes by. Where the issues are is that there has been good recognition of it. This is the good thing. All international guidelines talk about communication of SUDEP and the importance of communicating its risk factors, whether it be the NICE or the AN. Every single developed country has its own guidelines, which again reinforce these matters. So there is no ifs, ands, or buts about it. It's a very much about early on, preferably in first appointments, you should be talking about SUDEP. So that's almost laid down in stone in one way. It's pretty there. But the big challenge which we have regularly encountered has been that there is a discrepancy. There is institutional hypocrisy which exists where people talk about it, but when you actually look under the bonnet, you don't get what you are wanting to have there. And there is a discrepancy between what people with epilepsy and their families and their supporters want versus what we are delivering as clinicians. And I think a big challenge has also been about how do we measure that? What is a good communication? What is communication? What is good communication? What is required? How do we tailor it to the person who's at the receiving end and who gets communicated to? So there are multiple variables and it's a very multifaceted problem which we are dealing with. And I think understanding the scale of the problem required us to almost understand how are we going to measure it and how do we actually bring a common language to explore that between different countries, clinical systems, and culture. And that led us to actually putting together a validated approach to build some common questionnaire so that we can actually capture what is important for families, patients, and clinicians generally to be talking about. And one of the easiest ways in which it can do it is, of course, look back and see what is there. And we did that. So we looked to identify all the surveys on SUDEP counseling, analyze and compare the methodology, and we found 16 studies which were relevant to us, and we fitted them together to see what happens. And our search results showed that out of 16 surveys, which involved 4,000 doctors and 30 countries, we had, when we extracted the data, we had, 36 themes. We divided the 36 themes into essential and non-essential, and basically had a criteria, pre-designed criteria about what we consider as essential and non-essential. It's all in the paper, and every paper that I showcase here, it's free to access. Feel free to access it. I'm reliably told that each paper of mine gives 3 nights of good sleep, so it's well worth it on that front too. But equally, the findings which we had was finally we had 9 question themes which met the criteria, and we had SUDEP Action as which is a national charity in the UK and very prolific in the world of SUDEP and making a difference there. And they were our supporters with regard to looking through it and co-authors on this. And finally, we came together to put together 10 questions and themes as the validated themes there. So that was very much the engine of our work, which was there. Where did we go with that? Well, we went across and we have published, as I said, various papers in different countries. There is papers from, I think, Sweden, Europe, Hungary. We got Spain, and we got Norway and England. And we finally brought all of that together with a view to comparing each other too. And that was the 5-country study, which I've been asked to sort of highlight here. So the 5 countries are here, as you can see: UK, Sweden, Hungary, Spain, and Norway. And what were our findings in these studies was basically, we had 313 neurologists pooled across the 5 countries. And what we did find is that there is substantial variation between these countries about who communicates SUDEP to newly diagnosed patients. So it ranged from 4% all the way to 53% in England. And there was significant inter-country difference in the amount of time neurologists spent in not just discussion of SUDEP, but also actually in epilepsy care itself. So first episode patients or probable patients in Spain got only 20 minutes. And in that, of course, the big challenge is how do you actually even discuss SUDEP in that? And I think there was a lot of frustration from the Spanish neurologists about the time and efforts which are allocated for them on this. And there were significant inter-country barriers to SUDEP communication. So that is there. I'm just going to extract some of the 2 major key questions which we had there. So one is, when is SUDEP discussed by neurologists? And as you can see, the dark blue is UK, the light blue is Hungary, Norway is orange, the grayish thing is Sweden, and Spain being a sort of, yellowish sort of thing, or yellowish orange. So first of all, we have all patients. So neurologists who discuss in these countries with all patients, well, the gold medal goes to Britain. 12% of all its neurologists tend to discuss with all their patients, new patients, about SUDEP. So even with a winner at 12%, 88% are still not getting it. So that's where it is. But look at the rest of the others. It's really poor there. Then we have, for new patients only, as you can see, the winner here again, UK has done well with 53%, but 47% don't get it. But when you think about Spain, only 4% are discussing SUDEP with a new person. Then when you think about when there is a perceived change of risk by a neurologist and they discuss SUDEP, you can see that Spain leaps ahead there. But the question here is, what does it mean about perceived change of risk? This was quite a trick question in itself, because at the end of the day, that's a subjective avenue. So how do you actually objectify it and work it out? So that was something which never came across in that. Then at the request of the patient and family members, again, you can see that it's much better, but still a variance and still a lot of miles to go here. And I think, again, UK does well in that, but there is generally, it's pretty middling in the. And this one very much about when the neurologist remembers whether they need to do it or not. So that's left to ambiguity there. And I wouldn't want to be at the receiving end of whether my doctor is going to remember or not to discuss. And very worryingly, as you can see, never is quite a concern. And I think UK does well in that only 1% says never in neurology, but you have then other countries like Hungary and Sweden, where a quarter of people nearly neurologists don't discuss SUDEP at all with their patients in epilepsy. So that's a concern. Then I would just lay out to you as to why is SUDEP not discussed. So time, no rocket science there. People feel very constrained about time. The issue about complexity. So the challenge which is there is that the more complex, the more need you should be about actually discussing SUDEP. So the fact that there is a complexity means that, and you're avoiding discussion SUDEP because of the complexity is a bit of a oxymoron here in one way and doesn't fly across each other. But again, you can see that there is a variance there. Where the people perceiving low risk, and we asked specifically about what they mean by risk, and we got a whole bag of answers there. And that was one of the themes which emerged, is that people couldn't actually pinpoint. It's a subjective phenomena about risk. And again, that seems to be sort of mitigating people's intentions to discuss and actually supporting them not to discuss SUDEP. A perceived sense of distress by families and patients is leading to a large chunk in most places. You can see that quite a high numbers are saying that that's one of the reasons they don't discuss it. There is a slightly patronizing attitude of, well, the patient or the family might not comprehend what the discussion is about and why talk about that with them. So that's there in that. So you can see that there are quite a few potpourri groups of factors there which are very challenging and issues there. So I put together this slide about where are the different countries. It's almost like a motorway, a 5-lane motorway or a 5-way highways, which is there with different countries on different lanes. And where are we with regard to the key elements of discussion of SUDEP? So if you take UK, in the UK, we are very confident that it's very important. And we do know that it's very important. There is some amount of work still required to make sure that discussion and risk is sort of mitigated and there is an objective way to talk about it. Time constraints is a challenge, and we do need to quantify that and to help our clinicians and neurologists particularly to structure that. Patient comprehension, thanks to the work done by our charities, particularly SUDEP Action, is really high and up there. And we have, I think, very uniquely bereavement support in the UK, which SUDEP Action provide. When it comes to Norway, as you can see, importance is variable depending on who, where, and why from the neurology perspective. Discussion of all risk and change. I think Norway, funnily enough, has a long way to go, and from what we understood. And time constraints, patient comprehension seem to be a sort of, again, middling ground, and they have no bereavement support as such. You can see Hungary does pretty neutrally in most things, and expectations are lower possibly in the patient group and lack of that, but equally, discussion and risk change are marked with significant efforts needed, and that comes across in our studies there. Spain recognizes the importance but struggles with time, and I think that's a huge frustration for them. And again, they are less patronizing about patient comprehension and work. A sort of a rabbit out of the hat for me was actually Sweden, and I think Professor Thompson was also quite stunned with this, is that there was a considerable low level of acknowledgement for importance in Sweden, discussion and patient comprehension was sort of a bit more this thing. But it is variable because we, of course, have limitations of who responded to our survey. But you can then argue that those who responded were motivated to respond and were more proactive. So that fits across this whole paper, which is free to access. Very quickly, again, I think the way we can actually go forward, which is, I've talked about the good, the bad, the ugly, but I think the future very much about is we should be focused on grassroots training and education, safety checklists which are validated, which needs to be put into action. So there is opportunities to actually build these, and there's foundations to build it. Machine learning and AI work is coming through really strongly, and that's a very positive thing which is happening with the Bayesian methodologies which are there. Apps and sleep, including myself, we are researching into sort of circadian rhythms and work around that. So it's looking the future looks positive, but only as much as we can engage with the grassroots and work from there. Thank you very much for inviting me here and sharing my views here.
Thank you very much, Rohit. That's great. As I mentioned, we'll save questions for the end, and you can put your questions in the Q&A section. So I will ask Johan to share his slides and give us his presentation. Thank you.
Yes, thank you. Thank you very much for inviting me. It's a pleasure. And I've been asked to talk a little bit about a survey under the ILAE, so the International Epilepsy Organization Task Force on SUDEP, regarding the use and recommendations for wearable seizure detection devices. I was involved in collection and analysis of the data, but of course a lot of more senior persons were also involved in devising the actual survey. But I will start with a little background. What is the problem, and what was the state of knowledge when we started this survey? So as all listening to this webinar will of course know, seizures are common and sometimes the consequences are very severe. And seizure detection devices, they are improving, but implementation in healthcare is not really straightforward. It's not clear when and for which patient. And against this background, already before the survey, there had been a special task force within the ILAE with the Clinical Neurophysiologists International Association and the ILAE to create recommendations based on the available evidence. And the need that was perceived was dual from a clinical point of view. So automated seizure detection would be great, and it's needed to decrease morbidity and mortality associated with seizures, but also there is a clinical need for objective seizure identification and quantification. And this group decided to focus on tonic-clonic seizures because it has a clear link to SUDEP and also to severe injury, that a quarter of patients with tonic-clonic seizures sustain at least one serious injury per year. And what they asked was, can automated devices accurately detect tonic-clonic seizures, including those starting as focal seizures and evolving to bilateral tonic-clonic ones? And also, can automated devices accurately detect impaired awareness seizures without tonic-clonic components? And they did a huge literature review looking at almost 2,000 articles and ending up including 28 articles and finding that there was high-quality evidence for detection of tonic-clonic seizures, both generalized onset and focal to bilateral tonic-clonic seizures, and moderate evidence that the devices were able to detect seizures without the tonic-clonic component. So having decided this, they then had a Delphi discussion, which is basically an iterative discussion where you return to the issues based on questionnaires and where these experts try to balance the benefits of seizure detection against false alarm, the burden of using them, costs, etc., and come up with recommendations. And what they came up with was that they recommended using clinically validated wearable devices for automated detection of tonic-clonic seizures when there are significant safety concerns, especially in unsupervised patients who do not share a bedroom and where you can do something, a rapid intervention within a few minutes. But they acknowledge that this is an expert recommendation and that it needs to be implemented in an individual way. There was no recommendation made for other seizure types because there was much more need for research and development of devices and clinical practice. So this was the background, that we had these expert recommendations that led to this question. Well, what is the state of these recommendations? How are healthcare systems using guidelines, and what do individual physicians think. So the ILAE SUDEP task force did a survey. It was both to ILAE chapters, so countries, asking, do you have national guidelines on seizure detection devices, and to physicians globally, asking them about whether they would like to use such devices. And regarding the guidelines, most countries, 70%, responded that they have no guidelines. A quarter use international guidelines, so guidelines from another country or big countries. Only 4% said that, yes, we have national guidelines on when to use seizure detection devices. We asked about the model for procurement, and about half of the countries responded that it's most common that patients get this without or outside or without assistance of the healthcare system. They get it on their own. It was quite common for patients to pay the full cost, or that reimbursement was only partial. We also did an individual physician survey, and trying to do this, or asking individual doctors about their habits, it's of course challenges, and you have to understand that it's a very self-selected respondent crowd. But only 40%, we got 157 responses from quite a lot of countries. Only 40% were aware of any guidelines. And then we used case vignettes, so different clinical situations that we varied. We said that there had been previous, so what if this is the patient and this is the seizure frequency? And then we added, what if there were previous injuries? What if the seizures are nocturnal, etc.? And we also varied the time of the respondent. And I will not go into all the details, but this way you can sort of understand the willingness to prescribe seizure detection devices. And the factors considered very important in influencing the decision seem to be the availability of a responder, the frequency of tonic-clonic seizures, if there were nighttime seizures, and if there had been previous injuries. And what is especially interesting is that if you look to the far left or the far end of the slide, it was very rare if there were tonic-clonic seizures that physicians said that I would never prescribe a seizure detection device. So the willingness to use the devices, I think, is there. So to sum up, that there are now ILAE recommendations for seizure detection devices for tonic-clonic seizures, and that is that they should be used when there are safety concerns. And based on self-selected responders, clinicians seem willing to prescribe such devices, but it's still a long way to go in the field. Most countries have no guidelines, and awareness of these guidelines among international physicians seems quite low. But I agree with Rohit there that there are many positive messages here about the willingness to use the devices. So I think it's more now on a strategic and perhaps leadership level to really develop national guidelines and push implementation. And with that, I think I will close my talk. Thank you once again very much for inviting me.
Thank you. Thank you very much, Johan. Very complimentary presentations. Thank you. And our last presentation, and then we'll go to some time for questions, is Dr. Eugenia Rosa. So Eugenia, I'll ask you to start sharing your slides. Great.
Thank you so much for having me as a part of this very important conversation, because I believe that most families living with epilepsy already carry enough fear. So why would we be talking about SUDEP at all if we think about that? Well, it's because I believe that avoiding the conversation does not avoid the risk. So this webinar will still be about safety, honesty, and partnership, and not actually about fear. The following story might hit a bit close to home to some of us. It's about a 17-year-old boy who had his seizures that were mostly controlled. The family thought things were going okay. Nobody had discussed nocturnal seizures with them, neither SUDEP. And after a serious event, the family asked, why didn't we know, or why didn't anyone tell us? I think that question changed how many physicians actually think about SUDEP discussions today. So what is actually SUDEP? It's something we already know about this. This is why we're here today. It's something rare but real. I think the most important thing we need to take home with us is that many of the risk factors are modifiable as long as we can identify them and we know about them. Going back to guidelines, why do doctors actually use guidelines nowadays? People may often think that guidelines are some set of rigid rules, but actually they're not some kind of recipe. If we were to compare epilepsy care as a journey through maybe uncertain terrain, guidelines are actually the shared map, not actually the drivers. So they do help physicians remember important safety issues, discuss difficult topics consistently, reduce variation in care, and share evidence transparently. We've seen that there are quite a few guidelines available out there, but what do they actually say? Most guidelines actually have a more simpler message than it sounds. And they do recommend discussing SUDEP with people with epilepsy and their families, reviewing seizure control on a regular basis, identifying individual risk factors, and of course, supporting adherence and safety planning. So the goal of them is not to actually frighten people. The goal is to prevent people from being alone with preventable risks. So why are these conversations so difficult for so many of us? People might feel anxious about it. Things might seem overwhelming at some point. There is a certain amount of distrust if they were never told about SUDEP before. But at the same time, fear is a two-way street in this case, because clinicians also may fear to cause distress. They might fear that they're damaging hope. They might fear that they don't have enough time to discuss, or they're uncertain about wording the whole discussion. There might be cultural barriers. And most importantly, there's always this question about not knowing when to bring this subject up. But often silence comes from discomfort and not actually from lack of caring. So we all know that real life is much, much messier than guidelines. We all know that, we're clinicians. So guidelines may fit neatly on paper, but real life rarely does, because we have short clinic visits. There's already an overwhelming sensation when we have to talk about seizure control and medication changes, tackling mental health issues. There might be language barriers at some point. There's talking about fragmented care systems, but actually people do remember the conversations that were never had. So how are these guidelines actually helpful? What they do well is that they normalize the SUDEP discussions, they improve consistency, they allow awareness, they increase awareness, and they support shared decision making, and they empower people at the end of the day. But they do fall short in some aspects, and what they cannot do is replace individualized care. They cannot predict exactly who will experience SUDEP in their lifetime. They cannot, unfortunately, solve healthcare system limitations, and they cannot remove uncertainty. We have to remember that they are tools, and that compassion is what actually gives them meaning. If we go back to numbers, we know that around 7% of neurologists actually discuss SUDEP with all people. 41% rarely, but what's most important, that more than 80% of people actually want to know about and want to be told about the SUDEP risk. Us as clinicians, when we do follow guidelines, when talking about SUDEP, it's more likely when the clinician has had epilepsy training, has had a personal experience with SUDEP. We have an ethical obligation to disclose. And when it comes to patients, when the patient has clear risk factors, or the family and the person is actually proactive about it and they ask directly about SUDEP. Where guidelines are actually helpful for us as clinicians is that they give us a framework and tell us what and when and how to say it. At least we try to get that out of that. and they provide evidence-based numbers. It's much more impactful to say some people might experience it than 1 in 8 in 1,000 adults per year. It helps us support individualized counseling. And I think that that is very important, and something that I personally do mention it every time. It validates the fact that seizure freedom, especially from tonic-clonic seizures, will strongly reduce SUDEP risk. So, what about devices and seizure detection? As Johan just mentioned earlier, we know that technology can support safety, but it cannot replace human care, seizure control, or shared awareness. We do have a lot of options nowadays. We live in a time when we're lucky to have a lot of devices, whether they're seizure alarms, wearables, bed sensors, nighttime monitoring devices. We do have a lot of options. And when it comes to the physician perspective, guidelines, as we've seen earlier, are cautiously supportive because some devices may help detect seizures. They might indeed improve nighttime supervision, and they can reduce caregiver anxiety, but evidence is still evolving. So there's no device guarantee that it will 100% prevent SUDEP. And there's also always a chance of false alarms and actually missed seizures. Coming back to the paper that was discussed a bit earlier, physicians do tend to recommend this type of devices, especially in the cases when we have tonic-clonic seizures, there's been a previous injury, there have been nocturnal seizures, and most importantly, where there is somebody there next to the person that is able to intervene in case of emergency. When it comes, again, coming back to the guidelines, I'm just going to point out where they fall short for devices, just as Johan mentioned earlier. In most countries, there are no national standard for wearable seizure devices. In most countries, people just pay out of pocket for them, so they're not reimbursed. And that might be actually a problem, especially in middle and low income countries, because it's something that's prohibitive to most people. And there's not high quality evidence on whether these devices actually prevent SUDEP. But the most important safety tool at the end of the day is still partnership, because people should feel free and able to ask the important questions. What is their own individual SUDEP risk? How can we reduce it? If we can discuss nighttime safety for that person, would the device help, or whether the risk should be reassessed at some point? So good epilepsy care is not something done to people with epilepsy, it's something built with them. So this is something that we hear often from the people that we work with. People say that they wish that they had been told about SUDEP earlier. Even though it was scary, they did feel a sense of relief, and that knowing the risk helped them make changes and gain awareness, because information delivered with compassion and can reduce fear, and it will reduce fear, and it will not increase it. So why do we keep having these conversations? Coming back to where we started, it's because every SUDEP discussion is ultimately about something deeply human, keeping people safe so that they get to live the lives they planned. Because knowledge is protective, conversations do matter, people deserve honesty and compassion, families are always our partners in care, and silence should never be mistaken for safety. The goal is not to live in fear of epilepsy, but the goal is to live safely, fully, and informed. This is actually a video from last year, because every year on SUDEP Awareness Day, with our team back home pictured here in the center, we do participate in awareness events, and this is something that we do in memory of the people that we've lost. And I'm very grateful to work with a lot of NGOs, our own charity, Neurocare Association. And again, I want to mention, it's a big shout out to our team and to our team leader, Dr. Raluca Telanu. I know we are very fortunate in our center because we do have a very nice framework for working with people with epilepsy, and especially having SUDEP discussions. And I do realize that we're very lucky that in each and every one of these discussions, there was always a psychologist next to us. So this allows us to give them the best possible way to actually do have this important discussion. So thank you.
Thank you very, very much to all our speakers, and especially to Eugenia for really summarizing the issue so well. And we now have time for questions, and I'll go through some of the questions. I'll just start off not with a question, but maybe with a bit more of a fact to say, in fact, if you look at, like, we're talking about here the fact that there are guidelines and recommendations for healthcare practitioners to follow with regards to keeping people with epilepsy safe. But time and again, we've seen that those aren't always taken up by the healthcare practitioners. And if you look at the literature in general about whether basically doctors follow guidelines, the answer is about 34% across like all types of cardiologists, nephrologists, all kinds of doctors, surgeons. So only about 34% of doctors follow guidelines. And when you consider kind of there's models people have looked at to try and understand, well, why don't they? They really talk about like leakage, and the leakage can happen between agreeing with the guidelines or adopting the guidelines or following the guidelines. And leakage can happen at all those places. One of the things that I think I've learned through some work that I've done before studying guideline adherence in child neurologists, people treating children with epilepsy, is that some of it has to do with education and whether, you're not going to talk about something unless you feel comfortable about it, right? So if I don't feel I know enough about SUDEP, when a family comes and wants to talk to me about a disease or disorder, if I don't feel I know about it, I'm not going to want to talk about it, obviously. And in most settings, then, I would say I need to go get more information and come back to you. But let's go to some of our questions. Just so you know, you can put questions either in the chat, which some people don't seem to be able to access, but that's okay because there's also the Q&A. So the first, it's actually from Charles McClinnan. It's a little bit more of a comment than a question, but I will share it with the group and then we can get some feedback on it. So Charles writes, in the US, African Americans die of SUDEP more than any other group. And I'm familiar with that work as well. SUDEP is not discussed amongst families based on a meeting that I attended last month and a research meeting. And I've been under the care of an epileptologist for 20 years. So perhaps maybe we can start with Rohit, but anybody can weigh in on this. Do you think there are certain populations that are more likely to receive information from their healthcare provider?
I think there is a natural bias with regard to information. And for that, I'm going to shift slightly out of SUDEP to one of our recent studies, which we did around people with intellectual disability and epilepsy and all their mortality. So we looked at, in England, we looked at 5 years, 2017 to 2021, and we identified nearly 10,000 people with epilepsy and intellectual disability who died in that period. Not all of epilepsy, but 16% died of epilepsy. And the average age of death for that population was 56, compared to those who don't have epilepsy and intellectual disability, it was 63, compared to, say, somebody like me expects to live to 80 and collect my pension in England. But when it was ethnic minority, people with intellectual disability of Afro-Caribbean and or Southeast Asian groups with epilepsy, 36. And it was good numbers.
36, more likely 36.
No, 36 was the average age at which they died.
Okay.
And that's in England, which is an economically developed country with free access to healthcare as anyone else, the same level of care. So this shows that there is a massive skew, not just based on race, but also special populations and need. And it also, there is a fear among special population groups. We do know that the research suggests that people from Tower Hamlets or areas where there are more ethnic minority groups are less likely to go to their GP to ask about problems. They're more afraid of social care. They're quite concerned and they're much more about family oriented and lacking the knowledge. knowledge itself is not delivered to them, and we don't keep an eye on things like stigma, issues with regard to how it is felt about what people view the epilepsy as in these populations. Where is it? So a lot of work that needs to be done to unwrap that, but it's quite stark. It's a huge
Yeah.
difference with regard to that.
I'm just realizing actually it's kind of interesting. We have 4 different countries represented just in the panelists and the moderators. So that's really, really great. Go ahead, Eugenia. What do you think about kind of equity across epilepsy care?
Yeah, thank you. I think my take here is that there's a lot of assumption about understanding with certain
An assumption, an unfair assumption, right?
Assumption about understanding.
Exactly.
Because we might believe that certain families will not be able to understand complex risk information, or they will not be able to act on prevention advice, or they will become too anxious. So these assumptions, they might lead to unequal communication. Yeah.
A very unfair assumption. And in fact, in every other scenario where we practice medicine, it is the expectation upon us as practitioners that we will explain things so that people understand them. And so, nobody takes a patient to the operating room for surgery unless they feel they understand the risks. We should be trained in how to explain things. So even if we have an unfair assumption that people will not understand the information we share, that is not an acceptable barrier. First of all, the assumption is inappropriate, but even if there are circumstances in which people have barriers to understanding some types of information, I believe it is our obligation to provide it in a meaningful way. Rohit, and then perhaps Johan has a comment as well, but go ahead, Rohit, your hand is up.
The other thing which we have found is we have our EPSMON app, which is free for people to use to help their risk management and things. We have got around 6,000 people with epilepsy who tend to use it and update their risks from time to time. So it's got over the last 10 years, regular usage of it. But the skew of it, we've just been doing all the data analysis, is towards white women who are more concerned on that, less about those who are men. Ethnic minority groups representation is very, very, very low in take-up of these. And it's free to access. And it's been put on the BBC, ITV, you name it. It's been advertised. SUDEP Action, curated. We've got a huge data set of that, but still, you can take the horse to water, put a straw on
big
it.
Work to do.
It's not drinking. Yeah, exactly. So there are big challenges, and I echo Eugenia on that. So
we have big work to do. Johan.
Yes, maybe I'll just add a few comments.
Please.
So I think it's very interesting with the socioeconomic aspect. I think I would suspect that we have the same problems in Sweden, especially with regards to perhaps country of origin, and because we've had a large immigration that we haven't really, in the last 10 years, that we haven't really done a lot of research on. I think that would be very interesting to see. I would also like to highlight that there are some problems with translating surveys across cultures that is a bit difficult. So for me as a Swedish physician, understanding risk, I know this because I go to a lot of it means something else in the Swedish context. So I think
Tell us, what does it mean?
Well, I think many of the physicians who responded would say that they also do not understand the implication of the risk. So in the Anglo-Saxon and American system, you have a lot of there is a lot of information about risk percentages, but we have a dual system where we communicate the risk, but we're also the doctor is obligated the responsibility is always on the physician. Patients cannot consent to unacceptable risks. So it's always the doctor's fault regardless. So we have a slightly different
okay,
as
that's
a professional,
interesting.
you're held to a so even if the surgeon does tell you about all the risk, he or she is still responsible for if it was a motivated decision or not to do the surgery. So I think it's different. It's difficult to translate the results. But I think this I think the background to the Swedish result, which I wrote an article with Torbjörn after the survey that we have to really improve regarding SUDEP information. I think one of the reasons is that we have had a lot of focus on that epilepsy should not have, be a limitation in your life. We've had a very positive, pro-activities message in collaboration with our patient organization for decades. So I think that is why there is also a lot of uncertainty about how to handle this. Now there are very clear guidelines. We should inform about SUDEP risk. We should do it structurally to all patients. But I think that is why there is some hesitation about how to go about it.
Thank you. That's very helpful. Rohit.
Yeah, I think Johan's very right there. But also, I think what's stark is also the difference between something like Sweden and Norway. And I think there are so many cultural, we presume the cultural equalities when it's not true. And it's about attitudes, because I just finished in India, the neurologists, the pediatricians, and the psychiatrists there. The pediatricians and psychiatrists, they didn't know much about SUDEP. But the neurologists, 98.5% of them actually knew about SUDEP, but then they didn't want to tell the patients about it. It was a very patronizing, why should I tell them? It's like, why should they know? It was not even like, I don't want to scare them. I don't think they should know. I know about SUDEP. That's good enough. Now they don't need to know about it. So it was quite a shock there. But it's a cultural fabric.
There's a huge cultural piece to this. I'll just kind of summarize or close this aspect of our discussion a little bit to say that working with the International League Against Epilepsy, we're actually undertaking an development of an expert guideline, which now I'm not sure anybody's going to listen to, but hopefully around how to talk about SUDEP and SUDEP counseling and when people should be counseled about SUDEP, which is pretty much always, but how to do it. And we've got representation from across the globe, as is the practice of the International League Against Epilepsy. And I'm anticipating to see quite vast cultural influences kind of from different cultures for sure. I have a couple other questions. Muriel Lamond asks for Johan, do you know if there are any countries where detecting devices must be used in institutions dedicated to hosting people with epilepsy?
No, not that I'm aware of.
So that would be kind of like if a kid is admitted to my hospital and I don't have him like on EEG or whatever, do I get him to wear a wrist-worn device or something?
I think that's a very interesting question. Not to my knowledge that it's mandated, but I mean these. I think we have had some Dutch studies in Europe about the value of seizure detection devices in supervised residence, etc. I think that it could be very interesting, but I don't know about it. I think it's really our healthcare authorities here in Sweden. They struggle with it's hard to explain because the studies on seizure detection devices and mortality or quality of life, they have not been done. And that's what they want. That's what they want to pay for it. So that could be a very important step, I think, to show that it actually
saves lives
with mortality or helps with.
Yeah, I mean, my impression, but correct me if you know differently, is that in fact, we're not really going to be able to get good data around seizure detection devices and saving lives because the numbers don't pan out.
Exactly.
Years ago, Philippe Rivelin and Dale Hestorfer did the math on this, and you would need to give out a humongous number of devices, even though SUDEP is a massive problem. I talk about it constantly. I'm a huge advocate. It's thankfully not common enough that you could actually figure out whether wearing a device reduces SUDEP risk. But the quality of life studies, those are doable. Those are completely doable. And, when we talk about devices and quality of life, that's important because we shouldn't assume that it makes people's lives better if they go off too often, which we call false detections or false positives, if they're uncomfortable, if they have stigma associated with wearing them, then they may not make people's lives better. And we need that data, don't we? Eugenia, please.
Yeah, just following up on what you said, it's actually a discussion that I've had recently with one of the parents. They quit the detection device because of the anxiety they had because of it.
Interesting.
Yeah, very interesting.
Yeah.
Yeah. And I've definitely had families who have tried a variety of different types of devices until they find the one that kind of works for them. And Muriel just wrote a follow-up. She says, thank you. But she just also said, couldn't devices in hospitals be a good means of testing the devices? So in fact, that is how some of the studies were done. There are studies, aren't there, that were tested in hospitals. But then, the follow-up that I've heard is that, in fact, you need to make sure they work out of hospitals. Because like if it works in a hospital where you've got a nurse and a doctor and people are lying in bed or whatever, that's different than does it work on the bus or, in your home environment. Rohit.
It might be me in Cornwall in one way, but I tend to do home visits regularly and sometimes into residential homes. And
Okay.
there are times when I pop into the person's room and the audio video monitor battery would have been over. It's not working. It's there. So it ticks the box of it being there. A couple of times I haven't seen it plugged in. So things haven't actually been plugged in. So it's all the basic stuff. And once I saw this nurse carrying a whole basket of monitors, and it had no label of which room it belonged to or what. And it's these sort of things where I think mistakes happen at the coal face, where things which can be easily prevented or mitigated don't get accustomed into, because it is that I think families do a very good job, but it's when people become older or move into care, I think there's a challenge in that and how that happens. And that, of course, there is a much higher SUDEP risk then, because the amount of seizures, pharmacoresistance, and I think that requires some unpacking at some time.
We have 2 minutes and time for one more question. I will apologize to Gardner, but I know she can follow up later with regards to her question. But I am going to ask Rohit. Simon Lees said that you showed that Spain is good at communication to the patient. Why is this? Simon says, I have epilepsy. My brother died from it. I'm sorry, Simon. I don't understand why specialists can't include it within the subject of risk management, so a more general communication. So what are they doing right in Spain? That's a good question. I don't know. We don't have anybody from Spain here, but...
No, I think the thing is, I do feel that in Spain, the expectation of it goes back to what Johan talked about. I think the public or the average person with epilepsy, so we got a person who's doing our sabbatical with us from Vincent's team. And it's quite interesting. She was saying that the expectation which a client or a patient brings into our service is much higher here in the UK. And their level of awareness, their level of engagement, their level of knowledge with the families and others. So they act as partners to us, as opposed to a bit more top-down hierarchical picture in something like Spain. So I think there is that. Again, it's a cultural thing, whereas in the UK, we are very much partners. That's the way we say that. So.
Eugenia did a lovely job about talking about the need for partnership, right? And very, very important. And Johan, last comment, and then I'm going to close us out with a quick
excellent. I think it
discussion.
It should be in the specialist consultation, in a close to the risk management. I think it's, yeah.
And actually, I'll just say we've actually learned over more than 20 years of doing this. I've learned that you can't just throw this down people's throats, and it's better to have a general discussion around epilepsy and epilepsy safety, which is going to include things like water safety and driving and fires and all these things. So anyways, this has been such a great discussion. Thank you so much. I've really enjoyed it. And it's a topic very near to my heart. So I've really enjoyed it. So thank you very much. The last comment I want to say is a special thank you to Selena, Eduardo, Heather, and Anas for joining us. Oh, pardon me. That's from another document. Obviously, a tremendous thank you to Eugenia, Johan, and Rohit for your talks today and for this engaging discussion. As I mentioned at the outset, the webinar has been recorded and will be posted soon on PAMI's YouTube channel, so you will be able to find it there, and there's a bunch of other good content there as well. And then have a look at my slides. So the 2026 PAMI conference will be held on December 2nd and 3rd in Denver, Colorado. The second is dedicated to families affected by epilepsy, and the third is a meeting that combines people affected by epilepsy, clinicians, scientists, researchers, and it's an amazing 2-day experience to speak about mortality related to epilepsy right before the annual American Epilepsy Society conference. Registration information will be available soon, so check our website. Thank you, everybody. Have a great day.
Thank you.